first guest speaker, which is none other than Professor Taofeek Owonikoko.
Good morning, distinguished ladies and gentlemen. I will also stand on all existing protocols. And I'll be reading the citation for Professor Taofeek K. Owonikoko. Professor Taofeek K. Owonikoko is the Executive Director of the University of Maryland and Stewart Greenebaum Comprehensive Cancer Center, where he has made significant contributions to the field of oncology. A board-certified medical oncologist, hematologist, and internist, Dr. Owonikoko is renowned for his work in thoracic oncology, preclinical experimental therapeutics, and biomarker discovery. His research primarily focuses on translating promising laboratory findings into clinical trials, particularly in lung cancer. Dr. Owonikoko has secured substantial funding from the National Institutes of Health, NIH, the Department of Defense, industry partners, and private foundations. His groundbreaking work has resulted in multiple clinical trials at both institutional and national levels, and his contributions to the field are reflected in his impressive H index of 83, with over 250 original articles and more than 44,000 citations in high-impact scientific journals. In addition to his role at the University of Maryland, Dr. Owonikoko serves as Chief of the Division of Hematology and Oncology and the Stanley M. Marks Oncology Hematology Associate, endowed chair in the Hematology Oncology Leadership at the University of Pittsburgh School of Medicine. He is also the Associate Director for Translational Research and co-leader of the Cancer Therapeutics Program at the UPMC Hillman Cancer Center. Dr. Owonikoko is an elected board member and treasurer-elect of the American Society of Clinical Oncology, a leading global organization of oncologists. He has received numerous accolades, including the Michael C. Christian Oncology Development Lectureship and Award from the NCI, the Henry Hansel Award from Small Cell Lung Cancer from the International Association for the Study of Lung Cancer, and the Leadership Development Program Award from ACCO. Born in Nigeria, Dr. Owonikoko earned his medical degree from Obafemi Awolowo University, a PhD in anatomic pathology from Helchen University in Germany, and a Master of Science in Clinical Research from Emory University. His career has been dedicated to advancing cancer research, improving patient outcomes, and mentoring the next generation of clinical and research leaders. Ladies and gentlemen, no further, please welcome.
I want to stand on the existing protocols, and I want to thank our host today. It's a great honor and privilege for me to be back here 26 years later to interact with this audience. And I'm very grateful for the opportunity for us to explore areas of collaboration between University of Maryland, Baltimore School of Medicine, the Greenebaum Cancer Center, and Lagos University Teaching Hospital, the College of Medicine, as well as other institutions around the country, built around our Institute of Human Virology, Nigeria, which has been part and parcel of the fabric of this country for the past 25 years. In the interest of time, I'm going to go quickly, a little bit quick to catch up us on time, given all the other activities we have, including going to Akoka to meet with the Vice Chancellor. We do not want to have the Vice Chancellor waiting for us. So please, I apologize if we go a little bit fast through the slides. Thank you. So these are my disclosures. This should not have any bearing to the content of my talk today. But why are we here? Part of the reason why we decided to come here today is to build on the existing partnership that we already have with Nigeria in the area of communicable diseases. But when it comes to non-communicable disease, we view this as a generational problem that we have to confront sooner or later. And what this is showing is the World Health Organization burden of non-communicable diseases over the past 3 decades, showing that across the continent of Africa, if you look at West, South, North, and Central Africa, non-communicable disease continue to rise. And the steepest rise that you see is actually in West Africa. And we all know when you talk of West Africa, you're actually talking of Nigeria. So this slide really speaks directly to Nigeria that we have a major challenge on our hands going forward when it comes to oncology and oncology care. What we know today is just the tip of the iceberg. It's also projected that over the next 20 years, cases of cancer diagnosis as well as death related to cancer will increase by almost 80% between now and 2040. So we have to get going and be prepared to meet this challenge that is going to stare us in the face sooner than later. And when you look worldwide, cancer is a major burden everywhere. But if you look at the cases of cancer diagnosed across the world, certain things are very common, mostly solid tumor diagnosis, breast, lung, colorectal, and prostate being the 4th most common cancer worldwide, with almost 20 million new diagnoses of cancer each year worldwide. If you look at the distribution of cancer diagnosis in Nigeria based on the limited data set that we have, you can actually see that that almost mirrors what you see in the rest of the world. So whatever we do outside the country is going to have direct bearing to what is going on in the country. And part of what I want to do today is just to share some of our work in an area that may not seem relevant today to the country, but potentially could also help leverage what we're doing outside the country to help transfer of knowledge, expertise in a bi-directional way to meet this challenge that is going to come our way very soon. So I'm going to spend the next 10 minutes just showing a little bit of the type of work that I do and how this has influenced the field of thoracic oncology. So I'm a thoracic oncologist, so I only treat patients with lung cancer. That is all I do. That's what I know. But we try to do this both in a backward and forward translation approach, meaning it doesn't matter where the knowledge is coming from. You can take it back to understand it better, or you move it forward to apply it to actually impact patients. And I know in the audience here are my colleagues and teachers from many decades ago, where I started here in pathology training, and then once I got out of the country, I had to take a detour into clinical medicine and retrained as a thoracic oncologist. But I never left my passion for pathology. And what we know is if we look at pathologic diagnosis over the last 3 decades, this is actually a very, very telling slide about what has changed in the field of oncology. In the past, we just consider lung cancer to be one single diagnosis. You send your pathologist slide, they tell you it's lung cancer, and then you go and treat the patient. Later on, we observed that small cell and non-small cell do not behave alike, and then we started treating them differently. As we started breaking down non-small cell lung cancer and treating them differently, we also observed that those with squam versus non-squam or large cell respond differently to different therapeutic agents. I will tell you a short story of how we came to molecular subtyping of non-small cell lung cancer. Like I mentioned before, we used to just consider non-small cell to be one disease. But preclinical work was done showing that when you activate EGFR signaling and you activate the EGFR promoter under a doxycycline control, when you activate that promoter and EGFR signaling is activated, you actually promote faster cell proliferation and you reduce cell death. When you turn off the promoter, you get the converse. Proliferation goes down, measured by Ki67, and apoptosis goes up. And that is what you need for cancer to develop: uncontrolled growth, inability to die, and that leads to tumor development. But this knowledge did not come to us immediately. It had to come through trial and error, mistakes, and serendipity, where the first attempt to target this pathway in non-small cell lung cancer was actually in unselected patients. Erlotinib was given to patients regardless of what is the driver. As long as they have a lung cancer diagnosis, they were able to go on this pivotal trial that led to the approval of erlotinib, but just not by much. As you can see there, patients treated with erlotinib did better than placebo. That is because at the time this study was done, we actually did not have any standard option for those patients. So we allowed every patient to go on, and we barely made it out that erlotinib was better than placebo without selecting patients to understand why they're responding. Subsequently, epidemiologic studies were done trying to understand who are the responders. And we went in the wrong way thinking that this has to do with ethnicity, gender, smoking status. So for about a decade, we were selecting patients based on those clinical characteristics. Are you a smoker? Are you from Asia? Are you a female? Then we say, if you are, you're likely to benefit. And then we started conducting trials that way. But the main advancement actually came through deep science at Mass General Hospital as well as Memorial Sloan Kettering, where people identify a small number of patients who responded well to this agent. And I want to emphasize that you can have big impact from small study. You do not have to do a 1,000-patient trial for you to gain some insight into something that will drive the field. So based on this 9-patient trial, they identified patients who got EGFR TKI and responded very well within a matter of weeks. The good thing is they had tissue samples from those patients, and they were able to sequence the sample for those who responded and compare it to those who did not respond. Fast forward, they were able to identify mutation within the kinase domain of the EGFR gene as something unique to those who responded to that treatment. And that was confirmed in preclinical study and also confirmed in terms of the binding pocket for the drugs that we use, that those drugs actually bind to the kinase pocket of the EGFR protein. And that led to the birth of targeted therapy in non-small cell lung cancer, with EGFR being the model that paved the way. Subsequently, we've now gone ahead to compare targeted therapy like osimertinib to chemotherapy, no longer against placebo, because now we know you cannot afford to just give those patients placebo. So when you compare osimertinib to chemotherapy in those patients with this unique type of EGFR mutation, you can see that those who got osimertinib did significantly better than those who got chemotherapy, whether you look at progression-free survival or you look at overall survival. And unlike where we started from, where we thought maybe gender, ethnicity would drive the response, when you look at the subset analysis, there was actually no subset where osimertinib did not perform better than chemotherapy. So the power of science to drive what we do in the clinic cannot be overstated. Now, we've moved from using this agent in the advanced stage incurable setting to the adjuvant setting where patient potentially could be cured. And this is the latest study comparing patients who underwent surgical resection and then got chemotherapy as well as osimertinib versus not getting osimertinib. This study conclusively showed that disease-free survival was better if you got osimertinib versus if you only got chemotherapy in the adjuvant setting. This also translated into improved overall survival for those patients. And some of these patients actually did not get any chemotherapy, they only got the targeted therapy. So this is a real sea change in terms of how we treat patients with lung cancer. So where are we today when it comes to non-small cell lung cancer? Starting from EGFR, this is the way we profile our patients now, because it's not just EGFR that we know to be a driver alteration. I will always tell people it's malpractice in current day practice for you to treat someone with lung cancer without knowing the status of all these alterations, including EGFR, KRAS, MET, RET, BRAF, NTRK. These are all agents now where we have targeted therapy option, and it turns out that these are all mutually exclusive. So you cannot get away with testing for one and say it's not there and not test for the rest. So a case for comprehensive testing for patients going forward. Now, it's not all hunky-dory. It's not all positive. When we treat patients with this agent, at times patients will develop resistance. And the question is, what do you do when patients develop resistance? So how do you understand why someone is no longer responding to the treatment? We do know that about 60% of patients, when they stop responding, it could be because they've developed some mutation within the EGFR domain, or maybe some of the bypass track pathways that will allow the cell to continue to grow, even in the presence of the targeted therapy. But 30 to 40% of our patients who stop responding, even after the deepest sequencing effort, you may not be able to find the reason why they are not responding. So that's an area of investigation and an area of work that my lab has tried to work to understand what are the drivers of resistance in that cohort of patients where you do not have a known driver alteration. So I will use as an example of a population to bench to bedside approach in terms of things that we could develop locally as we start to treat patients with this type of agent, and we learn from them, we understand who is responding and who is not responding. But we need the infrastructure to be able to do that. So one thing that we're very lucky with in the US is a very, very robust surveillance mechanism for all patients diagnosed with cancer and their outcomes and the type of treatment that they received. So working with some of my mentees then, who are now independent faculty of their own, as well as a collaborator from another institution, we actually asked the question based on work done by others, that when you target estrogen receptor signaling, you can improve the outcome for patients with non-small cell lung cancer. We stood that hypothesis on its head, and we asked the question of androgen receptor signaling. Would that contribute in any way to outcome for patients? So that is the work that these two fellows did with me when they were with us. And we were able to use the SEER Medicare database to identify patients who had concurrent diagnosis of lung as well as prostate cancer, so that they would get treatment for lung cancer and androgen deprivation therapy. And then we could see at the population level, if you got androgen deprivation therapy, was your outcome better? Of course, this is unselected patients, but we could see a significant trend that patients who are on androgen deprivation therapy had better outcome for their lung cancer treatment. So with that observation, which does not prove causation, we had to then go back into the lab to understand why that is. So we got tissue samples from the lab, and we tried to see whether or not androgen receptor expression is present, one, and whether or not it's differentially expressed. The summary of this work is that we found that androgen expression, if you just look at the receptor itself, it's actually very, very low expression across different histologic subtypes. But when you look at adenocarcinoma, you have a trend towards higher expression of androgen receptor. But then molecular subtyping, looking at tumors with EGFR mutation versus those without, show that you have a lot of downstream genes that are androgen responsive elements being enriched in those tumors that are EGFR mutants. And when you look at the outcomes for those patients who had FOXA1, which is a surrogate for downstream regulated gene under androgen receptor expression, we saw that the presence of androgen actually conferred a worse prognosis to those patients. So being able to target AR could be a way to further improve the outcome for such patients. Then we conducted preclinical work using colony formation assay, where we looked at osimertinib by itself. Darolutamide is an androgen receptor antagonist. And you could see that you had barely any significant activity with darolutamide, some activity with osimertinib in limiting number of colonies formed. But the combination of those two agents actually wiped off most of the colonies. Moving into the animal setting, we did in vivo experiments that then showed that the combination of darolutamide and osimertinib outperformed the single agent alone. We used two different models to be sure that what we are seeing is actually accurate and you can replicate it. We've actually done this now in about 4 different models, and we got the same result. So with that level of data and evidence, we are now moving this forward into a phase 1 trial of patients with EGFR mutant non-small cell lung cancer who will get darolutamide and osimertinib as a way to either overcome resistance or enhance the efficacy of osimertinib. So this study is going to be open at our cancer center before the end of the year. The other area I mentioned is immunotherapy. One of the greatest advances we've had in oncology is the introduction of immunotherapy. And this is just a cartoon to show the dominant pathway that we target currently for immunotherapy, where program death ligand 1 and its receptor, program death 1, these are known biologically relevant mechanisms for normal immunity control. So when you have inflammation, there is a way for the body to stop the immune response, and PD-1 signal is one way for that to happen. So when you have the ligand binding to its receptor, it induces the death of T cells. In tumor cells, there is now known to be aberrant expression of PD-L1, which is not supposed to be there. So when that is there and you have immune cells in close contact with the tumor cell, the binding of the ligand to the receptor on the surface of the activated immune cell will actually lead to the death of those immune cells and allow the tumor to escape anti-tumor immunity. So the strategy is to create an antibody that can block that interaction between the ligand that is present on the tumor cell from binding to the receptor on the immune cell, thereby keeping the immune cells active, and that will lead to anti-tumor effect and tumor control. So how have we done with this agent? This has been now in development for almost 12 years. Nivolumab was one of the earliest agents tested, and this is an example of a patient with significant disease burden in the right lung, where the entire right lung was almost completely replaced by tumor, went on nivolumab, and within about 6 months, you had almost complete resolution of the disease burden in the right lung. So this is the type of story you see in patients. Of course, this does not work in every patient. But this has opened the gate now where, at least in lung cancer alone, we have almost 7 different agents, either fully approved or approved in combination with other agents as treatment for patients with lung cancer. And this is the development pathway for this agent and what we currently do. Going back to 2015 to 2021, you can now see that immunotherapy is part and parcel of what we do, both in newly diagnosed patients as well as in those who have been treated with other agents and no longer respond. And this is also relevant for all the different subtypes of non-small cell lung cancer, both squamous and adenocarcinoma, and more recently, even for small cell lung cancer. This is now an option of treatment for those patients. This is not for you to really see the reason for this slide is to show the number of pivotal trials that have been done worldwide that led to the approval of those agents in patients with non-small cell lung cancer. So there is a lot of work, and there's a lot of opportunity. If we develop the local capacity, all of these are global trials. And in clinical trials, speed matters, quality matters. So if you can demonstrate that you can do things very quickly and do it very well, you're going to be player in this field where every company wants to get their drug tested in the broadest population of patients possible. The other area is cell therapy. When we give immunotherapy, antibody-based immunotherapy, we give the drug. We don't know whether it's going to go to where we want it to go. We assume it will, and we believe it does because we see patients respond. But the more advanced way of doing immunotherapy is actually to collect the patient's immune cells, harvest the cell, train those cells outside the body so that they can recognize the immune cells, expand them, grow them into billions of cells, and then infuse those cells back into the patient after you've trained them. So this is the so-called cell therapy that is now a major component of how we treat patients with hematologic malignancies. And indeed, this is supplanting a lot of patients going through classical standard bone marrow transplants if they're otherwise eligible. This is an example of a patient treated at my former institution, University of Pittsburgh, who got one of these type of cell therapy, CAR-T as we call it. That was the patient with a plasmacytoma that was no longer responsive in the left jaw. Day 10 after the infusion of the CAR-T, you can see there's greater swelling. And then 2 days later, that swelling almost completely disappeared. The reason you had this swelling was the immune infiltration of the CAR-T into the tumor immune microenvironment that then led to the destruction of the tumor cells and complete resolution of disease. So this is a very involved treatment that is actually not available everywhere in the US, but at the University of Maryland, Greenebaum, we are lucky to have our own on-site GMP facility where we can create the cell and infuse into patients without them having to go anywhere else. And this is the example, the PET scan on that patient before and after treatment. And you can see there very widely metastatic disease pre-treatment, and then post-treatment you could barely see any activity again in the patient. One area that I mentioned I spend a lot of time actually trying to develop drugs for the treatment of patients with small cell lung cancer. An area that bridges the antibody-based therapy and cell therapy is what we call bispecific T-cell engaging therapy. And the concept here is if you just give the antibody, you don't know where it's going. If you want to infuse the cell, it's too laborious. Can you train the antibody to recognize the immune cell and recognize the tumor cell? So that is what bispecific T-cell engaging antibody does. you have a construct that recognizes CD3 as well as DLL3 in this case, where you can then identify the tumor cell through the DLL3 that is expressed and identify the immune cells through the CD3 receptor. And when you do that, you bring the immune cells into close proximity to the tumor cell, leading to tumor cell lysis, immune infiltration, and T-cell proliferation. So there are now a number of these agents currently in development. Tarlatamab is the one that is most advanced in development, but you can see that the basic construct for all of them is more or less the same. You find a tumor-specific antigen, and you find an immune cell antigen receptor, and then you link both of them through this bispecific T-cell engaging antibody. This is one study that was a global study that I had the privilege of leading. This was a worldwide trial in patients with small cell lung cancer, where we treated patients with tarlatamab, and these were patients with small cell lung cancer, where if you do not do anything for them at that point in the course of their disease, they will be dead within 2 to 3 months. So we were able to enroll patients regardless of what they've received, and show that patients that receive different doses of tarlatamab, starting from very, very low doses to the highest doses, actually we did see response across different doses. But we wanted to know whether or not we were going forward with the right dose. So what we did was to compare a small dose of tarlatamab to the highest dose that we tested, so 10 milligrams versus 100 milligrams. And whether you gave 10 or you gave 100, actually the response rate was more or less comparable. What we observed was more toxicity with the 100 milligram dose. And this trial, showing an example of the first patient that we treated with that agent on that trial, led to the approval of tarlatamab as the first-in-class bispecific T-cell engaging antibody for patients with previously treated small cell lung cancer. And earlier this year, based on this data, that showed that not only are those patients responding, you also have durability of response. You know, we always joke in oncology that if you wait long enough, every Kaplan-Meier curve will come to 0. But when we see this is a tail of the curve that we really want to see, suggesting that potentially we might actually be curing some of those patients. We are very, very careful not to say that because we've not had a long enough follow-up to be able to say that we're curing patients. But the possibility is there that with immunotherapy, we may have opportunity to cure about 20 to 30% of patients with advanced stages of their cancer. On the basis of that trial, the FDA approved tarlatamab earlier this year as standard of care therapy now for patients with previously treated small cell lung cancer. So, how is this relevant to what we're here for? You know, we can all do research, different types, various complexity, but you also have to make sure that the research that you do is relevant to the environment. We talk about curiosity-driven research, a lot of which we do. We want to do it just for the knowledge. We don't know what we're going to use that knowledge for immediately, but potentially down the road that could become useful. But you also have problem-driven research because you have a problem today that you need to solve. And I think in limited resource environment, we have to focus more on a problem-driven research, where we collaborate with other centers to engage and participate very, very well in curiosity-driven research. So how could we domesticate, as we say, some of these efforts going on globally to the local environment? So I want to show some examples of, even in the US, we do have areas of underserved community that we also have to struggle as to how do they gain access to some of these new developments. So when immunotherapy was approved for patients with lung cancer, we looked at all the approved drugs and we looked at the FDA data. Across 5 pivotal phase 3 trials that enrolled almost 3,000 patients, there was less than 50 patients of African ancestry on those trials. So the question is, if you develop this drug not enrolling those patients, how do you actually know that the drug works for that population of patients? And that is where I feel an environment like LUTH, and Nigeria in general, if we develop the local expertise, know-how, and engagement, we may be able to participate in these type of trials and then be able to answer locally relevant questions during the conduct of the trial. So at Emory, where I was before, we take care of about 40% of our patients are African Americans. So we ask the question within our own population of patients to say, well, If this patient did not all go on immunotherapy trial, we are using them for our we are using immunotherapy for African American patients. How relevant is this to our population? There's always, when you look at any type of targeted therapy, chemotherapy, surgical intervention, radiation therapy, and you compare African Americans to Caucasians, there is always the disparity in outcome. A lot of it due to access, but when you take out access, we know that there's still some degree of disparity, which we've not been able to sort out in terms of the biology. But what we did when I was at Emory was to look at our patients treated with immunotherapy and those treated with chemotherapy. And we observed that if you treat a patient with chemotherapy, we'll see the same thing that we've always seen, which is African Americans did worse than Caucasian. But when you looked at immunotherapy in the same population of patients, African American patient getting immunotherapy, you actually do not see that disparity again. If anything, we saw a trend towards African American doing better on immunotherapy than Caucasians. But there was no way for you to have done any sort of subset analysis on the pivotal trials to be able to say that that is a potential research question that is worthy of further evaluation. So based on that observation, we wrote through ASCO a major piece talking about enrollment of racial minorities in clinical trials, that this is an old problem, but it's actually much more relevant in the era of immunotherapy. And a lot of organizations now in the US, including government agencies, are now paying particular attention to the diversity of patients going on clinical trials. So if we have the capacity locally in country, we could be able to contribute globally to this type of problem and try to solve them. So it's good to develop all these drugs, and we've done very, very well over the years. So if you look at drug development across tumor types, we are developing more drugs. We are developing many more drugs for each tumor type, and the pace of development is rising very, very fast. And this is for every category of agents you want to look at: targeted therapy, chemotherapy, biological therapy. But the problem is it takes a lot to develop these drugs. So when you go all the way back to 1975, where the biologics that we're trying to develop then were anti-estrogen therapy, it cost about $138 million in 1975 to develop a single drug from the lab to where it became FDA approved. In 2015, that amount has ballooned to $2.6 billion to develop one drug. So this is definitely not sustainable. And what that has led to is when you look at oncology as a business, over the past decade alone, the oncology business has quadrupled from a global $61 billion enterprise to $250 billion business. So there is a lot of money being invested in oncology. But if we invest all this, can people actually pay for it? So this is the per unit price of oncology drugs over the years, going back to 1965, where a newly approved drug will probably come out at an average of $100. Now we're looking at something that looks at about $10,000 per cycle of drug. This is not a one-time drug. Oftentimes for cancer patients, these are lifelong therapies. So if it's going to cost about $10,000 just to give one cycle of the drug, that is not something that is sustainable, not even in developed world. And we do have some that even cost upwards of $100,000 per cycle. And not to talk of cell therapy where it could run into millions just to do one. So how can we engage in that conversation is how do we promote affordability and access? We know that worldwide there's wide variability in pricing. Even the drug companies, they will not give you the same price to different countries. But you only benefit from that if you can actually show them the value that you bring. So knowing the amount of disease for different cancer types that's available in country, having the capacity to deliver the drug can give you a seat at the table where you can then negotiate a country-specific type of rebate that will then make the drug available for people in the country. And these are areas where I feel a place like Louth and Nigeria can play a significant role as we build the capacity for local expertise. The other area is generic medicine. You know, all of us think, oh, you have to go with the branded drug in order for you to get the efficacy. Even in the US, 90% of approved drugs, once they become generic, That is what we treat a lot of our patients with. And a lot of insurance will insist that you use generic because they are known to be just as effective as the branded drug. In fact, over the past decade, it was estimated that the US saved almost $1.67 trillion by using generic drug rather than branded name. So another area of opportunity for us as a society to see how can we partner with generic companies to come in, do validation trials, because before you get your generic drug approved, you still have to do some trials to show that it is equivalent to the comparator drug. And one area that I know that NSI is particularly interested in is in-country capacity to develop biosimilars. So when you look at biosimilars, they're the most expensive category of drugs. But even when you have biosimilars, the price does not drop until you've developed at least 4 or 5 different biosimilars in that class. So everybody develops their biosimilar, but they still want to charge the same price as the comparator drug. So when you have a situation like that, partnering with, NSIA, for instance, if they develop the local capability to be able to develop biosimilar for drug going off patent, would be a way to bring these drugs in country at an affordable price. And this is an example of what similar countries to us have done. I remember when we were all in school, we consider India to be our peer in terms of everything: education, science, technology, engineering. But I think we can all accept the fact that comparatively, India has done a better job than we have done as a society. And this is a small study that was done in India in terms of doing research that is relevant for the local environment and the local problem, where they looked at nivolumab, the same drug that I mentioned before, and they said, we don't really know whether the dose that you tell us to be using is appropriate for our population, and we get away with a lower dose of this drug. So they compared weight-based nivolumab, 3 milligrams per kilogram. So you can imagine if somebody weighs 100 kilograms or maybe 70 kilograms, you'll be giving them 210 milligrams. So they compared that to a 40 milligram flat dose. So about a quarter of what you would have given them if you are going by the recommended weight-based dosing. And they looked at the PK of the 2 doses. The long and short of that is whether you gave them flat dose or the conventional dose, both doses will give you a concentration in the blood that is expected to be efficacious. So you actually do not have to give that 200 milligram dose if you go by weight. You can just get away with 40 milligram dose. And in fact, when you look at the trend in terms of outcome, those who got the flat dose, the lower dose, trended better than those who got the 3 milligram per kilogram dose. So telling us now, based on this trial, they've moved forward to address a local problem that they have. Head and neck cancer is very, very common in India. So they compared that low-dose immunotherapy plus chemotherapy to chemotherapy alone. And they were able to show that when you do this, the addition of immunotherapy, which is the low-dose immunotherapy to chemotherapy, did better than chemotherapy alone. So in India, they are comfortable not giving 200 milligram dose to a patient with head and neck cancer based on this type of trial. So this is how you domesticate global knowledge for a problem that is really particular to your local environment. It's not all about drugs. There's also a lot of advances made in other things that we use to treat cancer. When you think about evolution of surgical intervention for lung cancer, for instance, going from having to perform pneumonectomy to having to do lobectomy, from open lobectomy now to VATS, now to robotic-assisted lobectomy. We've made a lot of advances, and we do have the expertise locally to be able to partner with, both institutions across Nigeria, but also institutions outside Nigeria, to be able to bring this type of expertise in-house, ask relevant questions. We know that when you talk about open or closed or VATS lobectomy, outcome is actually comparable. The only difference is VATS lobectomy utilizes less resources. So developing that type of capability in country is also a way to minimize utilization of resources, not just a way to acquire the latest and the brightest technology. And when you talk about radiation, I think next door to us, we know what is going on there. We've gone from the era of just using the cobalt to deliver radiation to where you can now, really target to the precise point possible of radiation delivery to minimize toxicity and still preserve efficacy for patients. And let's not forget the fact that majority of our patients are still diagnosed with advanced stages of cancer, which unfortunately are still incurable. So we need that local expertise for those who can deliver palliative care. So it's not all about medicine, surgery, radiation. It's about quality of life and quality of death. So giving treatment to relieve pain or alleviating a problem when you cannot deal with the underlying cause is really the basic principle of palliative care. And I think this is particularly relevant to a society like ours, where we do not have the resources to diagnose cancer very early, and even for those that we diagnose at all, we do not have the wherewithal to be able to give them effective treatment. So 1967 was really the beginning of the formal palliative care program in England, where it was actually led by the Catholic nuns, where they said, you matter because you are, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. So we need to bring this also into what we do as we try to take care of patients with cancer. So as we think of building local capacity, we should not forget the fact that palliative care should be part of what we want to bring in country. And this is the old concept of palliative care, where we say, oh, do everything you can, curative care, do everything, throw everything at the patient. And when everything fails, then move to palliative care. Actually, now we've shown conclusively that the introduction of palliative care at the time of initial diagnosis for patients with advanced stage disease improves quality of care, quality of life, as well as the efficacy of the curative treatment that you're trying to administer. And then finally, screening. We are better off not allowing people to get advanced stage disease. If you can stop them from getting the diagnosis at all, picking up the bad habits, maybe that is difficult for us to achieve, but at least if we diagnose them early, we might be able to bend that curve. So the reason I'm showing this, I've shown a lot of slides about immunotherapy. And I mentioned that we probably save about 20% of those patients in the tail of the curve. This is looking at low-dose CT screening for early detection of lung cancer in patients who smoked, considered to be at high risk. Adults, smoke for at least 20 years, what we got 20-pack year smoking history if they were smoking 1 pack per day, and they continue to smoke or they stopped smoking in the last 15 years. So a lot of people will do the fancy things because those are relatively small. You can scope it. This is really hard. And even in the US, we are struggling. This is an approved intervention. We know it saves life. But when you look across the country, the best state in the US, they were only screening about 12% of patients at risk for an intervention that is covered by insurance that you can get done, but only 12% of patients are actually getting that screening done. In my former state of Georgia, 3.8% of those at-risk patients getting screened. Maryland, where I am now, is even worse, only 2.9% of patients. So we recognize as a real opportunity, and at University of Maryland, in partnership with industry, we are launching an $8 million program with AstraZeneca, where we are going to launch a low-dose CT screening program across the state of Maryland, both using our facilities as well as mobile truck to get this to the population where they're going to benefit from it. And building capacity is not unique to us. We do not have to be ashamed for wanting to partner to build capacity. Even countries that we consider to be advanced, they continue to use their diaspora brain to develop their country. So this is a symposium I participated in China in 2018, where Chinese jackpass in the US were partnering with scientists in China in the area of lung cancer research, and we meet on a monthly basis. Those in China will log in, we will log in, and we all talk about what type of science is relevant to their community, as well as what we were doing in the US. So I think this is really an important area, and I'm very, very grateful to Professor Adeyemo and all the members of the Sickle Cell team here at Luth, as well as the Sickle Cell Foundation of Nigeria, for partnering with us to launch this clinical trial that is now ongoing here at Luth. And they are actually enrolling more here than we are enrolling in Pittsburgh. So talking about if you build it and you build it well, They will come. And I do think that this is an example that they will surely come. So we've been in country now for the past 8 days, and we've spent a lot of time in Abuja. Now we're in Lagos. And our goal really is to establish an institution to institution, institution to government, an institution to investigator type partnership. Building on the successes of our Institute of Human Virology Nigeria, we are really focused on the non-communicable diseases and trying to see what we can do, partnering through bi-directional flow of information and education, and focusing on what is relevant to the local environment and the community. I'm very, very hopeful that this is something that 10 years from now, we will look back and say, well, we started this 10 years ago and see what we have accomplished with that. And with that, I want to thank you all, and I hope that the next time I go to a conference and I see a slide like this, we're going to have some grains in Africa of where patients are being enrolled on clinical trials, and it's not all going to be blank. Thank you.
He maintains an active research group and has served as principal investigator and co-principal investigator on more than 25 clinical trials. Professor Gladwin has published more than 450 manuscripts with a global Scholar H index of greater than 120, which is pretty huge, just for reference. And he has also co-authored some clinical textbooks, including sickle cell disease, clinical microbiology made ridiculously simple, and critical care and hospitalist medicine made ridiculously simple. Some of his scientific discoveries include the finding that the nitrite salt is a biologically signaling molecule that regulates physiological and pathologic hypoxic responses, blood pressure flow, and dynamic mitochondrial electron transport. The reason why this is being reeled out is because this is very relevant in the context of sickle cell disease research. He also has characterized the role of hemoglobin and myoglobin as signaling nitrate reductases that regulates nitric oxide production under hypoxia, which is also very relevant for sickle cell disease research. And this is reflected in his 2003 publication on this work that has been cited more than 1,800 times in Nature Medicine. His work on the nitrite anion has led to development and licensure of intravenous, oral, and inhaled nitrites as a human therapeutic, with completion of animal toxicology, good manufacturing practices, formulations, and phase one trials with licensure of the drugs. Phase 2 trials of inhaled nitrite are underway for treatment of pulmonary arterial hypertension, and this is also particularly important, not just in the context of sickle cell disease, because pulmonary arterial hypertension is one of those disease conditions where treatment options are very limited. It is also relevant for the context for the treatment of metabolic syndrome and heart failure with preserved ejection fraction. In addition to the studies of nitrites, he characterized a novel mechanism of disease for hemolysis-associated endothelial dysfunction, which is also another key problem in sickle cell disease. This work has described a state of resistance to nitric oxide in patients with sickle cell disease, malaria, transfusion of aged blood, and other hemolytic conditions caused by scavenging of nitric oxide by hemoglobin that is released into plasma cells during hemolysis. These studies have translated into clinical and epidemiological description of a human disease syndrome, which is currently referred to as the hemolysis-associated pulmonary hypertension. Some of Dr. Gladwin's work in sickle cell disease includes the de novo trial of nitric oxide therapy for acute pain crisis in patients with sickle cell disease, the work-fast trial of sildenafil for pulmonary hypertension secondary to sickle cell disease, the EPIC trial of Poloxima 188 for vaso-occlusive painful crisis, the stereo SCD trial of the SGC simulator Sickle, and are currently running the SCD care, a clinical trial of exchange transmission therapy. I would once again like to welcome a very vast doyen and very knowledgeable scholar in the field of sickle cell disease, Professor Gladwin.
Thank you very much. I'd also like to ask that I may stand on the existing protocol because I'm not near as talented as he is to remember all the names and pronounce them so well. I do really want to thank Professor Bose Afolabi for her hospitality and leadership in sickle cell disease, and of course, Dr. Professor Adeyomo for her leadership in sickle cell disease. I very much appreciate the warm welcome this morning from our Chief Medical Director, Dr. Ademoyu. Thank you so much. Adeyomo, excuse me. And also, I want to thank my fellow Dean, and I want to thank the Associate Provost. Thank you for greeting us so warmly this morning. I'm very proud that I brought with me leaders from both Nigeria and the University of Maryland. We have a long history of a partnership of over 25 years with Nigeria at the Institute for Human Virology, Nigeria. And since the very beginning of this partnership, we and our leaders have focused on capacity building and true teamwork with Nigeria to address one of the great generational challenges, which was the control of the HIV pandemic. So with me, I have Dr. Abimoko, Professor Abimoko, I have Professor Mensah and Professor Takum, who lead the Institute for Human Virology in Nigeria, and I'm proud to say our faculty at the University of Maryland. So thank you for joining me here. Part of the reason I'm here, of course, is that I recruited Taofeek Owonikoko, a Japa, I've learned. I'm beginning to learn a few Nigerian words. And also Professor Adebamowo, who is a leader in cancer in Nigeria. And they're passionate about bringing advances in cancer care to Nigeria through a partnership with Luth. So I appreciate very much them being here with me. So I'd like to quickly ask Professor Adeyomo to come up here. I have a small token of appreciation that together we have partnered on the first of many to come clinical trials in sickle cell disease. And I want to, one, thank her for what she has given of her talents and her passion to treat patients with sickle cell disease. And I also want to thank her for this clinical trial partnership that we've started, which is the reason we're all here, because of the opportunity of what we can do together. So I have a simple backpack, but it's important because this is Under Armour, and Under Armour is manufactured, made, and headquartered in Baltimore, Maryland. And we have the University of Maryland School of Medicine. And the University of Maryland School of Medicine is the partner now to Luth as a major public university, right, in Nigeria. And we're in the top 10 of all the public university academic medical centers in the United States. So we're proud to build on this partnership. But I have another surprise. Give you the backpack.
Oh. I got this.
She says she already has a copy, so you can re-gift this. Yeah. You can give this to your best faculty or student.
All right.
So thank you.
Thank you. Thank you very much.
Thank you.
Thank you.
So I'll share a scientific story. How many people in the audience are clinicians, take care of patients? How many of you are scientists? Okay. I'm going to cover some basic and translational science and some clinical medicine. So I hope it will be clear. Do I point here or? Okay. So this is a slide that shows the burden of sickle cell anemia in children across the world. And the size of the country reflects how many children are with sickle cell disease. And so you can see, excuse me, you can see in a red-orange is more than 100,000 children born with sickle cell every year. And you can see the largest country in the world is Nigeria. But you can also see other countries in sub-Saharan Africa. Now, I'm going to talk to you today about a complication that adults with sickle cell as they get older develop. Because as patients get older, they develop end organ complications. And one of them is high blood pressure in the lungs, or pulmonary hypertension. And the right side of our heart pumps blood through the lungs, through the pulmonary artery, to the left side of the heart. And the left ventricle pumps blood to the brain and the kidneys and the body. With pulmonary hypertension, there's high blood pressure in the artery of the lungs. You can only measure it with an echocardiogram of the heart. You can't measure that high blood pressure on the lungs, on the arm, because it's inside the chest. So you look at it with an echocardiogram. And when someone has very severe pulmonary hypertension, they develop right heart failure, and the right ventricle dilates. And it was interesting that when you look at a 4-chamber echocardiogram in the heart with right heart failure in pulmonary hypertension, it looks very much like this map. And this is a patient of mine that had sickle cell pulmonary hypertension. This is the right ventricle, which looks very much like this. And this is the left ventricle, and this is the inner ventricular septum, which is being pushed into the left ventricle by the high pressure in the right heart. And this is an enormous right atrium. And you can see this person is developing right-sided heart failure. So this will help you remember the echocardiogram that you'll see in a patient with pulmonary hypertension, with severe pulmonary hypertension, but it will also show you and help you remember how important sickle cell disease is in Nigeria. This is another map from our textbook that I just gave to Dr. Adeyomo that shows Nigeria here and shows that, again, it has more children with sickle cell than any other country in the world, at greater than 100,000. In the entire America, in all of America, we only have about 70,000 of all patients with sickle cell disease. And this is just more than 100,000 children alone. And in the little dots, which includes Lagos, you can see the percentage of children that have stroke. And you can see that it approaches 5.4%. 5 to 9% of children will develop stroke, one of the deadly complications of sickle cell that happens early, between ages 4 to 7. Now, you all know about sickle cell disease, but this is an autosomal recessive disorder. There is a single mutation in the DNA that codes for hemoglobin. And this single substitution of a nucleotide results in a single amino acid transition from a glutamine to a valine at position 6 of the beta chain. This then results in an abnormal hemoglobin. Now, in the United States, essentially 1 out of 10, 8% of Americans have one copy of this mutation, sickle cell disease trait, a carrier state. But in Nigeria, 30 to 50% of the population, depending on the area, has one mutation and are carriers. So this is very personal for you. It's very personal for Nigerians, because I've learned over the last 5 days that you have to think about this and worry about this with your children, who you marry, who you have children with. So this is a very personal issue for Nigerians, I'm taught over the last 5 days. But in addition to that, in America, 1 out of 500 babies that are African American have sickle cell disease, have 2 copies. They inherit 2 copies from the mother and father. 1 out of 500. Here in Nigeria, it's as high as 0.5 to 3%. So again, very high prevalence of sickle cell in Nigeria. And the reason I think it's so important that we do something about this together across the country. I would love to see us think about a 95-95-95 strategy, like what you did for HIV. 95% screened, 95% treated with hydroxyurea, 95% with a response to hydroxyurea, and I'll talk about hydroxyurea later in some detail. What happens when you inherit 2 copies of the gene and you have a mutant hemoglobin S? Well, what happens is when the hemoglobin deoxygenates, the abnormal hemoglobin inside the red blood cell becomes sticky, and it polymerizes, it crystallizes, and it forms long crystals inside of the red blood cell, long polymer crystals. And if you were to look with an electron microscope and opened up a sickle red cell, you would see these long polymer bundles. Now, when you form this polymer within the red cell, it forms a sickle shape, which is why we called it sickle cell disease. But also the red cells become very stiff, very rigid, and they get trapped in the microcirculation, in the small blood vessels going to your body. And when these get trapped, they stop blood flow. And this effect is greater at low oxygen. Anytime oxygen drops, these red cell hemoglobin S polymerizes, the red cells become rigid, they block blood flow. And when you block blood flow anywhere in the human body, there's severe pain, ischemia and reperfusion. And you can have damage to blood vessels, stroke, ischemia injury to the kidney, to the liver, to the lungs. Any part of the body can have an ischemic insult. The second thing that happens when you have increased polymer crystal of hemoglobin S in red cells is the red cells hemolyze. They break apart. So a normal red blood cell, if you do not have sickle cell disease, will live for 90 to 120 days in your body, carrying oxygen to the body. But if you have sickle cell disease, hemoglobin SS disease, which is about, I think, 75% of disease in Nigeria, is it 25% SC? 10, so 90% hemoglobin SS. So with hemoglobin SS, the red cell will only survive 15 to 30 days because it hemolyzes. In fact, the average patient with SS disease will hemolyze 1 unit of blood a day and use 10% of their total metabolic energy making new red blood cells. Now, I don't know if you can see this from the back of the room. It's kind of small, but this is in the textbook. But this is what we now think to be the molecular mechanism of sickle cell disease. At the very top is what you learned in your biochemistry classes. And that is what I showed you before. The glutamic acid to the valine, the formation of hemoglobin polymer as oxygen drops, the formation of sickle cells, and hemolysis. What we now know, of course, is a little bit more. These sickle red cells block the blood flow. It's not just the rigid cells, but also there's inflammation and the expression of adhesion molecules like P-selectin, VCAM1. And these inflammatory molecules stick white blood cells and platelets and neutrophils and red blood cells, and they block the blood flow. And they lead to ischemia, reperfusion, injury. The other thing we've learned really from the work of my laboratory and other groups is that the hemolysis is not benign. The hemolysis releases hemoglobin into the blood, which destroys a molecule called nitric oxide. And I'll tell you a little bit about that. And also releases free heme. And heme and the ischemia reperfusion injury activate a new pathway called sterile inflammation. Sterile inflammation is when it's like you have an infection, but there's no malaria, there's no bacteria. It's your own tissue injury. And we know sterile inflammation is activated with trauma, breaking bones, with childbirth when it goes badly. But it also happens with sickle cell disease. And this activates a pathway called interleukin-1 beta and the activation of the inflammasome, which can trigger more inflammation. This, by the way, explains why a patient with sickle cell sometimes has a crisis if they bang their leg on the table, or if they come out of the water in the cold and the cold air blows on them, and it can activate sterile inflammation through these pathways. So in the world, there is a good news and a bad news with sickle cell disease. And the good news is that people are surviving longer and longer. In the United States, very few children die with sickle cell. Very rare to die with sickle cell in the US. And what we've seen in the United States and in Europe is an increase in life expectancy. This is life expectancy, and this is 45 years of age. Before 1970, about only 10% of people, or people lived only to about 10 years of age by average. And since this time, it's risen, and now people are living to a median age of 45. That means half the people live longer than 45. We have patients that are 80 years old in our clinic with sickle cell disease. Now, in sub-Saharan Africa, we have not achieved these results. There is still a very high infant mortality. It's estimated that almost 90% of children can die in the first 2 years of life because of the secondary infection with malaria, with dysentery. Infections will trigger severe sickle cell crisis and death. So in Nigeria, we still have to move this curve up. But the good news is we're able to keep people alive longer. Now the bad news is, as they're living longer, all of the recurrent episodes of vaso-occlusive crisis and hemolysis are leading to end organ injury. So in our adults, we're seeing more kidney disease and more heart disease, pulmonary hypertension. And because I'm in the United States, most of the patients I see are adults, and they're older, and they are developing these end organ complications. And I'm sure you're seeing more and more of this as your patients are aging as well. And these are the kind of chronic complications we see. We see pulmonary hypertension and heart disease. We see avascular necrosis of the hip. We see chronic renal failure. And it turns out that chronic renal failure and pulmonary hypertension are perhaps the greatest risk factor for death and morbidity in our adults as they live longer. So I'll just briefly talk on some basic science, and that is, how does hemolysis damage blood vessels? Why does hemolysis lead to pulmonary hypertension? And why does hemolysis lead to chronic kidney injury? And central to this is a signaling pathway in all of your bodies called the nitric oxide signaling pathway. And if you look here on the left, you have the blood flow. This is the blood. And this is the endothelial cell that lines your blood vessels. All of your blood vessels have endothelial cells. And your endothelial cells have an enzyme called the nitric oxide synthase. It's a little factory that makes nitric oxide. And it converts arginine to citrulline, and that makes a molecule called nitric oxide. And nitric oxide is a soluble gas molecule. It's a nitrogen and oxygen. It's a free radical. And nitric oxide is special because it opens up your blood vessels. Nitric oxide binds to its receptor, soluble guanylate cyclase, and it makes cyclic GMP, and cyclic GMP relaxes the muscles around your blood vessels and opens the blood vessels. So think that nitric oxide is improving blood flow. And all of you make nitric oxide in your body all the time. And do you know if you smoke a cigarette for 1 month, your nitric oxide production drops? If you have high cholesterol, your nitric oxide production drops. If you gain too much weight because you eat the bad American diet, your nitric oxide drops. And patients with sickle cell have low nitric oxide as well. Now the reason for this is the hemoglobin released from hemolysis reacts with and destroys nitric oxide. I don't know if there's any chemists in the room, but this is a reaction of the oxyhemoglobin with nitric oxide to make methemoglobin and nitrate. And this is a very fast scavenging reaction. It scavenges and destroys nitric oxide. Now, how did we figure this out? Well, we knew that this reaction was a fast reaction, and we've known about this reaction since 1850. But when I started my research, when I was a fellow at the National Institutes of Health, we observed that patients with sickle cell disease had higher levels of plasma hemoglobin. The red cell released hemoglobin during hemolysis, and that they had high levels of plasma hemoglobin, undetectable haptoglobin. And so we tested this hypothesis in patients with sickle cell. We brought 27 adults with sickle cell into the National Institutes of Health, and we infused into their arm. They found that it's associated with kidney disease progression. And this is their study. The patients that have hemoglobinuria have a high risk of chronic kidney disease progression. And if they have hemoglobinuria in dashed lines, they have a high probability of albuminuria progression. Now, recently, the NIH, I left the NIH about 16 years ago, but they continued to evaluate our cohort of patients with sickle cell, and they've now screened more than 600 people over those years. And this was a very nice study by Swile Thane, and she used artificial intelligence program to look at predictors of death in adults with sickle cell. And these are all the variables that she looked at, and this is the importance of the variable in risk factor for death, and these are all the variable. And look, at the very bottom is genotype, SCSS. It had very little impact on mortality. But look at the things that are above this. Measures of diastolic heart dysfunction, measures of right atrial pressures, measure of pulmonary hypertension like NT-proBNP. And look at this, measures of chronic kidney disease, high creatinine, high BUN. But look what's at the very top. The tricuspid regurgitant jet velocity and the estimated right ventricular systolic pressure. So pulmonary hypertension is the top of the risk. And in the study that she conducted, she developed a risk score using the number of variables. So in green, there were 0 to 1 risk factors. In blue, there was 2 to 3 risk factors. And you can see in red, with more than 5 risk factors, there was only about a 3% chance of survival to 10 years. We now know that there's an endophenotype or a syndrome that's associated with hemolytic anemia. The more hemolytic anemia, the more we see pulmonary hypertension, the more we see chronic kidney disease, lower exercise capacity, increased risk of death, and leg ulcers. Your patients with leg ulcers often are the ones with higher hemolysis. We think the free hemoglobin damages the microcirculation and causes the ulcers. And one thing to keep your eye out, now that you have echocardiography and POCUS, when we visited hospitals, everyone showed us they have POCUS, they have echocardiograms. Sometimes you'll see patients that come in with acute chest syndrome, which, as you know, is very common during VOE events. And if you do an echocardiogram, you'll see they also have right ventricular dilation and pulmonary hypertension. And we think that's because during chest syndrome, there's an increase in hemolysis, but also there's fat embolization and thromboembolization. You saw in the mouse how the platelets were activated, the neutrophils were activated. So that leads to acute pulmonary hypertension and right heart failure. So we always look for right heart failure in patients with chest syndrome, and we might be more aggressive about exchange transfusing those patients to try to save them. And they respond very well. The pulmonary pressure will normalize as they improve. So the last thing, I'll just briefly talk about therapy because you're the experts here on this. But number one, if you have pulmonary hypertension by echo, or you're developing chronic kidney disease, or you have a lot of episodes of VOE and chest syndrome, we strongly believe in intensifying hydroxyurea therapy. The second thing is, I think in Nigeria, our greatest opportunity is hydroxyurea therapy. We asked about the prices. It was about $3 a month. And I'm sure at a government level, we could negotiate lower prices. And you can compound the liquid hydroxyurea for babies. They're now treating babies at 6 months of age, and it's been shown to improve survival. So hydroxyurea is available, it's cheap, and I think we should do a 95-95-95 plan in partnership with IHV Nigeria. 95% screening, 95% treatment with hydroxyurea, 95% pushing the dose of hydrea for fetal hemoglobin induction. If you did it for 5 million people in Nigeria with HIV, it should be easy to do for sickle cell. And this is very important. Were you part of this study, the REACH study group? So this is called the REACH group. And this is a study looking at hydroxyurea for children with sickle cell in sub-Saharan Africa. And this study involved more than 800 children ages 1 to 10, and they gave them hydroxyurea. And there was 97% protocol adherence. In Africa, the patients listened to the doctors, listened to the teams, participated, and gave their children, their babies, hydroxyurea. So what happened in Africa? I hope you can see this is sickle-related events, and it's the number of events per 100 person years. And you can see a dramatic drop from over 100 to 25 in sickle events. Those are vaso-occlusive events, splenic infarctions, severe anemia. Now here was a surprise. Hydroxyurea does not treat malaria, but malaria infection plummeted. And this has been seen in all the Africa studies. If you treat children with sickle cell with hydrea and their sickle cell gets better, they're more resistant to malaria and they're more resistant to other infections. If you have sickle cell disease and you get malaria, it's very difficult to survive that. And this is vaso-occlusive pain dropping, transfusion dropping, chest syndrome dropping, and death dropping. So this is one of the strongest studies seen with hydroxyurea in Africa, and it shows that it works. So we should be doing this for all our children. When we visited Abuja Hospital, they said only 13% of their children were taking hydroxyurea. I don't know what percent we are here. Similar, 13%. In America, we're about 60%. But everything we do in Nigeria, we want to do together in Baltimore as well. We could try to do 95, 95, 95 in Maryland and in Nigeria as a team together. So what about transfusion? Well, in America, we have something called erythrocytophoresis, where we take all the blood out and we put normal blood in, about 4 to 6 units every month. It's very resource heavy, but we do this in patients with thalassemia major, for example, for a lifespan. So there is some data that chronic blood exchange transfusions in pulmonary hypertension and sickle cell can improve outcome. This study in France, this shows that the exercise, the New York Heart classification of shortness of breath gets better, and the pulmonary pressure drops. So there's case series and case reports suggesting that exchange transfusion helps. And it makes sense. If we took away the sickle blood and we put normal blood, we'd stop the hemolysis, stop the vaso-occlusion, and it should help keep people alive. So if you infuse this molecule, your blood flow increases. But we hypothesized that patients with sickle cell that had more plasma hemoglobin would have an inhibition of the nitric oxide. We hypothesized that the free hemoglobin in the blood would destroy the nitric oxide. So we did this simple experiment. We brought patients into the clinical center of the National Institutes of Health, and I put a catheter in the artery and a catheter in the vein, and I infused the sodium nitroprusside into the artery, and we measured the blood flow in the arm using a technique called venous strain gauge plethysmography. It's a fancy name for a little elastic band that could measure the swelling of the arm as blood flow increased. And this was probably our most important figure in this paper, which we published in 2002 in Nature Medicine. This is 27 patients where we measured the plasma hemoglobin right at that moment, and we measured the blood flow increase during the infusion of the nitric oxide medication, sodium nitroprusside. And the normal response to nitroprusside is about a 200% increase in blood flow. And what we saw was that we saw this. The patients with sickle cell that had no plasma hemoglobin had a normal response to nitric oxide. The nitric oxide worked normally. But the patients with more plasma hemoglobin had an 80% inhibition of their blood flow. And we saw this at high dose, intermediate, and low dose. So this is the first time that people saw a resistance to nitric oxide associated with high levels of plasma hemoglobin. And this result has now been reproduced in population studies and reproduced in mouse models of sickle cell disease. So not only does the hemoglobin scavenge nitric oxide, but the hemoglobin, when it oxidizes to methemoglobin, it releases the heme. And you may know that hemoglobin is a big molecule, but it has a heme group in it. And your own fellow African, Solomon Ofori-Akwa, who's the dean of the University of Ghana, he published this very important paper, and he showed that extracellular hemin can trigger the acute chest syndrome in sickle cell mice. And if you look over here, this is the lung, and he infuses heme from hemoglobin, and it causes severe lung injury, acute chest syndrome. And he showed that the heme activated sterile inflammation by activating toll-like receptor 4. Because if he knocked out toll-like receptor 4, the hemin had less of an injury. And this hemin triggered death. This is dropping survival, 100% survival, 0 survival. So this is 100% death. And when he infused the hemin, it caused lung injury and death. And this could be prevented by the toll-like receptor knockout. So not only was hemoglobin scavenging nitric oxide, it was also activating sterile inflammation through the toll-like receptor 4. And this is, maybe I can get your help to hit the animation. But before you do that, this is a very unique experiment. This is Dr. Prithu Sund, who collaborated with us on this. And this is a mouse. Now this mouse is genetically engineered to have human sickle cell disease. This mouse has a knockout. They knocked out the gene for mouse hemoglobin A, mouse hemoglobin beta, so there's no mouse hemoglobin, and they put a transgene of the gene for human hemoglobin S. Do you know the movie Frankenstein? This is a Frankenstein mouse. This mouse has sickle cell disease. And this mouse, you can test drugs and test mechanisms. Now what Dr. Sun did is he did a surgery. He put the mouse on a mechanical ventilator, and he put the mouse to sleep with anesthesia, so there's no pain. Don't worry, we're not hurting our mice. And he opened the chest wall, and put a microscope on the lung. No one's ever been able to see inside a mouse with sickle cell, to see the blood flow in the lung. And this is the first time someone was able to see, with a microscope, blood flow in the live mouse lung. And if you hit the video, this is blood flow in purple. All the blood vessels are in purple because there's a purple dye. You can hit that a few more times. And the purple is the blood flow. The black is the air sacs, the alveoli of the lung. So the capillaries go around the alveoli of the lung. And the red are neutrophils. The green are platelets. And notice that the neutrophil and platelets are activated, and they block the blood flow. So not only are the sickle red cells blocking blood flow, but the neutrophil and platelets are blocking blood flow. And what caused this to happen in the lung? He infused oxyhemoglobin. So if you give the sickle mouse oxyhemoglobin in the plasma, it triggers the activation of neutrophils and platelets. And over here, he gives just IV hemin. And you can see these neutrophils block the blood flow. Now, interestingly, if you give just hemin, you see more of a neutrophil blockade. But if you give hemoglobin, you see more of platelet and neutrophils. And that's because when you block nitric oxide, the platelets are activated. Next slide. The other thing that he was able to see is in the lung circulation, I think you can hit a video here too. In the lung circulation, this is blood flow going this way. He's now also looked at extracellular DNA in green. And not only do the neutrophils and the platelets get activated, but the neutrophils release their DNA. And these are called neutrophil nets. You know when Spider-Man wants to catch someone, he shoots a spider web. Well, our neutrophils, our white blood cells, when they want to catch bacteria, they release a web of DNA. And the DNA is sticky, and it binds to bacteria. Well, in sickle cell disease, when you give hemoglobin, it causes the neutrophils to release their extracellular DNA, which also blocks the blood flow. So now we're beginning to understand how a chest syndrome and crisis can be caused by hemolysis hemoglobin in heme. Thank you very much. So this is the last basic science that I'll show you. This slide summarizes the work of our laboratory and others over the last 2 decades, where we showed that in sickle cell disease, but also in other hemolytic conditions like malaria, like transfusion of old blood, paroxysmal nocturnal hemoglobinuria. In all of these diseases, the red cells hemolyze, and the hemoglobin can destroy nitric oxide. And the met hemoglobin, the oxidized hemoglobin, can release its heme. And that heme can activate sterile inflammation. And when you inhibit nitric oxide, you get platelet activation, pulmonary hypertension. When you release heme and you activate sterile inflammation, you can develop vaso-occlusive crisis and chest syndrome. And in the red, we have different treatments that people are developing to try to block this. For example, haptoglobin to scavenge the hemoglobin, hemopexin to scavenge the heme, and things like toll-like receptor inhibitors to block sterile inflammation. And this is the inflammasome, and there's studies now from Novartis blocking IL-1 beta signaling. Okay, so for the clinicians in the room, if that was too much basic science, I'll now turn to some clinical information. So what's the clinical relevance of hemolysis? Well, all of you know that hemolysis causes anemia, and a patient with SS has a hemoglobin level of about 7 grams per deciliter, which is low. Your level might be 14 grams per deciliter. But the second thing is it can cause biliary gallstones. You can get gallstones. And people knew about this for forever, right? But in the last 20 years or so, we've realized that hemolysis does more than cause anemia and gallstones. It also damages blood vessels. And one thing we all began to notice is that no matter what causes chronic hemolytic anemia, the patients will develop pulmonary hypertension and more thrombosis, pulmonary embolism, venous thromboembolism. And if you look, many diseases now are associated with the development of pulmonary hypertension, high blood pressure in the lungs, with that right heart failure I showed you. For example, sickle cell, thalassemia, intermediate and major, paroxysmal nocturnal hemoglobinuria, serocytosis, stomatocytosis. If you look on the literature, almost any chronic hemolytic anemia is associated now with the development of pulmonary hypertension. In fact, the last time I made these slides, there were more than 1,400 references of pulmonary hypertension and hemolytic anemia. Now in sickle cell, I'll tell you more about this, but very early on with the work of Oswaldo Castro, we began to see that pulmonary hypertension was common in our adults with sickle cell in the US and was associated with a very high risk of death. So we did a study when I was in Washington at the NIH, and we looked at patients with sickle cell that lived in the community that were not in the hospital. We went on radio stations, churches. We recruited everybody we could, and we measured the blood pressure in the lungs using Doppler echocardiography, sonography. And I'll show you in a minute how you can measure pulmonary hypertension with echocardiogram. But we published our results in the New England Journal of Medicine here, looking at how common pulmonary hypertension and showing that it was a risk factor for death in adults with sickle cell over 18 years of age. And this is how you detect pulmonary hypertension. You put the cardiac ultrasound on the chest. And for example, this is a 4-chamber view of the heart, where this is the right ventricle, the left atrium, the right atrium. And every time your right ventricle squeezes, there's a little backwards of flow through the tricuspid valve. 87% of us have a little bit of a leak through the tricuspid valve. So you can use that to estimate the pulmonary artery pressure. And the equation we use is we calculate, this is the envelope, the Doppler envelope of that backflow. And this peak flow velocity in meters per second, you can use this equation, 4 times the tricuspid regurgitant velocity squared, to estimate the pulmonary artery pressure. So this is not a direct measurement of pulmonary hypertension, it's an estimate of the severity of pulmonary hypertension. And a normal value for this TR jet velocity is less than 2.5 meters per second. And it has this sensitivity and specificity profile for diagnosing pulmonary hypertension. So what did we find in our study? Well, when we first started, we screened 195 patients with sickle cell disease. We've now screened more than 530 at the NIH. And what we found is that 67%, 2/3 of adults with sickle cell, have a normal pulmonary pressure. So if you're in this room and you have sickle cell disease, I just want to assure you that 2/3 or more of patients do not get pulmonary hypertension with sickle cell disease. And those are the patients that live a much longer life. But what I'm going to focus in is the subpopulation that develops pulmonary hypertension. And what we saw was that about 1/4 of patients had borderline increases in the pulmonary pressures, 2.5 to 2.9, and 9% had more severe elevations in pulmonary hypertension with the tricuspid regurgitant jet velocity of greater than 3 meters per second. And the sickle cell experts in the room, they all know this number, 2.5, because that's a number that we know, as you'll see in a minute, is associated with high risk. So when we followed our patients that were screened in this study, a very surprising thing happened, that the patients with a normal pulmonary pressure, they had a high survival. Now this is called a Kaplan-Meier survival curve. And a Kaplan-Meier survival curve, on the y-axis is the fraction surviving. 50% are alive, 100% are alive. Every time this drops over time in months, this is when patients die. So as you can see, if you have no pulmonary hypertension in America and you're an adult, you have an 85% chance of living for 60 months. Now, by the way, that's still terrible. 2 to 4% risk of death per year. It's still terrible. But look what happens if you have pulmonary hypertension. That's for borderline, and this is for high pressures. So only a 60% chance of surviving for 60 months. And the relative risk of death is 10, a 10 times increase of risk. And by the way, this is one of the highest risk factors found for sickle cell adults. It turns out chronic kidney disease and pulmonary hypertension are the highest risk factors in adults. So there have been many studies that have looked at this now. This is a meta-analysis, and these were all screening studies in different countries, and they found that about 20% of patients with sickle cell had a TR jet velocity over 2.5. And in almost all of these studies, the #1 risk factor for having a high TR jet was the severity of hemolytic anemia. So this hemolysis and nitric oxide destruction is a risk factor for developing the pulmonary hypertension. And these studies looked at mortality. There were 2 studies that I led, but other groups as well. And in all these studies, these were the numbers of patients screened. And over here you have the hazard ratio, which is like a risk ratio for death. And you can see in all of these studies, the development of a high TR jet velocity, high pulmonary pressure was associated with a high risk, relative risk of death. And there was a large study recently completed outside of Paris. This is downtown Paris, where we just had the Olympics. And this is the Henri Mondor Hospital outside of Paris. And this is a major center for sickle cell disease. There are many African immigrants that have gone to France, and they have sickle cell, and they're cared for here. And this place did a very large echo screening study. They published this in the European Heart Journal, and this is Pablo Bertolucci's work. They studied 656 patients with sickle cell, and they measured echo of the heart. And they found that a high tricuspid regurgitant jet velocity was associated with hemolytic anemia and had a hazard ratio for death of 6.81, essentially confirming what we had found in Washington. And they did a receiver operating curve analysis, and they found the best prediction of death was above 2.5, very similar to what we had shown 10 or 15 years earlier. And you see how significant the p-value, 0.001. And this is a very important figure. And this, in my practice, I see all the time. This is the TR jet velocity. This right here is 2.5. And this is probability of being alive at 36 months. And what you see is above 2.5, there's a linear increase in risk of death. The higher the TR jet, the higher risk of death. And if you have a TR jet of 3, you only have a 40% chance of living to 36 months. So we're very aggressive in the United States. When we see a high TR jet velocity, especially over 3, we're very aggressive about our treatment. Now, the gold standard for pulmonary hypertension diagnosis is a catheter. We put a catheter in the internal jugular and a catheter into the pulmonary artery, through the right atrium, through the right ventricle, into the pulmonary artery, and we measure the pressure directly. And when we did this at the NIH, we found that having pulmonary hypertension by right heart cath also strongly predicted mortality. So this is the probability of survival, 100%, 20%. And I'm very proud of this book. In chapter 24, we have a nice chapter by Dr. Makani, and Dr. Oheen Frempong, as you know, passed away a year ago. So we're very sad about that, but he was very proud of his contribution to this chapter. His son had sickle cell disease and passed from sickle cell disease. And all the art at the beginning of the book was provided by the artist Hertz Nazaire, and this is a piece of art that he called Hope. And so I'm inspired by this art. And he had sickle cell disease, and unfortunately he came from Haiti, and he was blind in one eye from sickle cell. And at times he was homeless, because in the United States we treat the patients, we think that they're seeking narcotics, and we haven't historically given them the best care, something we call systemic racism. And he suffered in his life and didn't get the best care possible. But he passed away about 2 years ago. But before he died, we gave him copies of the book, and he was so proud. He put on social media about the book and was so proud that he contributed the art to this book. So this is in his memory as well. Thank you. Thank you. Do I go down?
I thank all the professors here present. Professor Olu and Professor Karim were here much earlier. College admin, Professor Daramola is here. I didn't even see you beforehand. Dr. Annette, thank you so very much for coming. Professor Akomu, the guru, hematologist forever, my mentor. And thank you, Professor Adeyemo, for putting all this together. CCTRIS team, thank you so much. If I haven't thanked you yet, I do apologize, but we really have to leave here today. We've really enjoyed, I've learned a lot here today, and I'm sure all of us here have. Unfortunately, some people missed, but thank you so much, and thank you.